I'm really happy that we have some people still, although there are some competing events outside. So well, we are here. I will talk about the darker side of the transplantation that we are not very happy, we are not very proud about, because there is a substantial number of patients that really suffer and die because of what they are doing. We're trying to save their life at whatever price we may pay, but we must see the darker side of what we are doing. I have no potential conflicts. This is my first disclosure. And the second is I'm not going to talk about graft versus host disease, not a single word, because I think it deserves a separate session. So I don't want to talk about this particularly. We have some factors contributing to complications after hematopoietic stem cell transplantation. And from the beginning, we already may assume that this is a high-risk project and this is a low-risk project. We can always be surprised, but to some extent we can play with the data we have about the patients. So we have the indication, previous chemo, radio, disease status of transplant, pre-existing comorbidity, which in children is particularly not a big issue as in adults, conditioning regimen, donor type, degree and duration of aplasia, intensity of duration of immunosuppression, and the last one that I don't want to talk. And in fact, the non-relapse mortality, it's relapse due to complications. So if we could improve these curves, we can also improve the curves regarding the event-free survival and overall survival. And we see this is a really substantial contribution to that we fail with non-transplant, not relapse mortality. These lines, it is probably acceptable that this line, especially when you have the patient with high risk, is 20%. So this is something that we should think every time we have the indications from transplant. And this is a long list, and even dots, because there is always something that we cannot predict, and it happens. And this is the first time in my life as a transplanter I've seen this complication. But when we put this, we have this cytopenias, bleeding, oral mucositis, diarrhea. You don't see, but this is about acute chronic graft versus host disease, but we are not talking about that. So stem graft failure, early infections, post-transplant lymphoproliferative disorder, always driven by EBV, and organ injury toxicity. And then we have late complications. We switched from, previously it was thought that this is late effects, but I think it was too soft. This is not effect, this is a complication, the long-term complication. So in Sweden, we switched, we just erased the effect. Now it's called complication. Complications, they are already under the conditioning quite often. High-dose chemotherapy causing nausea, vomiting, direct toxicity, fluid overload, obviously. Total body irradiation in selected group of patients with nausea, vomiting. And if we do fractionation TBI on the kid, which is 3 years old, then we have to have, we do it in six fractions. This is 6 general anesthesia. So this is also a risk factor. Serotherapy, which is quite common when we use cytokine release syndrome, anaphylaxis, serum sickness. And serum sickness is not just like a Loch Ness monster, it happens. Complications due to cytotoxic effect of chemotherapy, radiotherapy on cells with high mitotic rate. This is this most annoying at the very beginning, that we have cytopenias and then increased risk for bleeding and infections. We have painful oral mucositis with erythema, ulcerations, bleeding. We have gastrointestinal tract mucositis with all these symptoms. And this is really bad thing for the patients. They really feel they've got this treatment. And sometimes this is the most difficult part for kids undergoing stem cell transplantation. Moving forward, that these all things with this high mitotic rate and damage to the quickly dividing cells, we have risk for infections, herpes simplex and Clostridium, norosapovirus, acute graft versus host disease as well. Then we have to think that it's probably not only the mucositis, but it may happen that we have some other factor behind. So mucositis, yes, but exclude the factors that could cause these symptoms. Management, adequate mouth hygiene, and the pain management. And I would say pain management is very important. Even in the BMT, we don't have general guidelines how to do how to cope with the pain, how to do a good pain management. So every center has its own guidelines, and then in Stockholm, this is clonidine paracetamol as the first line, and then continuous morphine and PCA if possible. Antiemetics, nasogastric tube and enteral nutrition very early. We don't have to wait. We usually go for transplant, and I would say advise, not force, but advise the kids to get the nasogastric tube. And start with TPN, PPN also quite early. They need energy support. They need energy much more than the healthy kids. Bleeding, another complication. Multiple risk factors with prolonged thrombocytopenia, mucositis, infections, acute graft-versus-host disease, thrombotic microangiopathy, liver toxicity, hypertension. Common sites for life-threatening bleeding on lungs, gastrointestinal tracts, or CNS. And you see incidence that the 25% patients experience hemorrhagic event and 9.9% with life-threatening bleeding. And impact on 3 years survival is that those without have 67% of survival, and with 17. So this is a complication that really contribute to the worst outcome. Transplant associated microangiopathy, Kirill has touched this problem a little bit. It ranges differently from 10 to 35%. Children who develop TA, TMA have significantly higher rates of TRM, and this is, of course, complex pathophysiology. Then we go to the results, and we see that this without are doing very good, with TMA are doing very bad, 0.30% is not acceptable. Features, hemolytic anemia, thrombocytopenia, hypertension, renal dysfunction, and it occurs rather early after transplantation. Median diagnosis, and almost all occur before day 100. And again, high rates of TRM. What to do with this? There is this is a very nice paper doing with very nice guidelines, and I would recommend to go through this because it's really very nicely written. And if you have no experience with this, this paper will really guide you how to handle the problem. This is from treatment, a control of infection, to adding cortisone, changing, switching, stopping calcineurin inhibitors, and then we have also, depending on the laboratory findings, plasmapheresis plus rituximab or Soliris. If we go further, that we have this SOS VOD. It was even more touched by Kirill, so I think we can skip some slides, and we go to the risk factors: the high-dose busulfan, single fraction of high-dose fractionated TBA, combination of busulfan and cyclophosphamide or melphalan. We usually keep a pause at least 24 hours between busulfan and cyclophosphamide or busulfan and melphalan. It helps. It also helps when you use busulfan and you do TDM. Then you are mid in the point that you don't overdose busulfan. These pictures have been shown previously by Kirill. Then we go for the prophylaxis, and we did prophylaxis before, but since I think June 2020, there's a general recommendation not to go for the prophylaxis. We of course judge every single patient, but yes. Doses of busulfan.
You probably use 16, right?
Yeah,
we use 14.
Yeah, we do. Yeah.
Oral,
so the dose doesn't matter. Mm-hmm. We use busulfan IV, and this is a very nice table, and I think the vast majority is given 4.8 milligrams per kilo in one single dose per day in 4 days IV in 3 hours. And then we target the TDM around the curve. Myeloablative is 19 units or 75 units plus minus 5 for the others.
And then you're giving 80% of that with no target.
And oral.
And
with-
oral,
and no therapeutic, not
No
a target, but not.
No drug monitoring.
Right,
Yeah.
exactly.
That's good. Okay. Good. So back to this, we don't do that, but we consider individually the patient, like maybe if I have osteopetrosis, I would consider anyhow, even there is no recommendation. Let's go for the treatment. Of course, euvolemia. This is all very often self-limiting disease. Okay. I thought that I need some tube, but so fluid restrictions and daily measures and the reasonable weight goal would be -2 to -5% from the baseline. Natrium restriction, minimizing exposure to hepatotoxic agents, pain control may require narcotics, paracentesis in some cases, avoid lipids in TPN, and sometimes it's necessary to have this patient on the pediatric ICU. The treatment, the defibrotide is really recommended, still recommended for the treatment. This is a standard dose, 625 milligram per kilo per dose in 4 doses, starting at the onset of DOD at least 3 weeks. This is expensive approach with some toxicities, which probably has also the limitations for using this. Don't mention the price. It's pricey and expensive even for Sweden. But frankly speaking, since 20 years in Sweden, I haven't seen the patients because we do this TDM, I haven't seen a patient in need that we had to start defibrotide. Infections, this is a big problem. It's a really big problem. The first is that there is a risk of transmission, and this is the one thing. And the second, that the most and life-threatening problems, the patient's own flora. And this is what we really have to cope. And we do screening for several viruses. We give prophylaxis for Candida, and we really have some problems with the central line. And as you told, Lawrence, the only thing that we have from the positive air pressure is probably protection from aspergillosis as the fungal or mucor. And then everything could be done in an open system. Prevention is better than cure, so there are standard precautions, and this is standard, like proper hand hygiene, single room, standard protective equipment for personal cleaning, injections, infection control, and prophylactic treatment, preemptive and empiric medication with antiviral, pneumocystis, antifungal, and some food restrictions. We are not so strict, really. So they can eat almost all, excluding this from the list. And we have different time points after the stem cell transplantation with different problems. It may happen that it's known that because of neutropenia and the mucositis, we have gram-negative bacilli, we have gram-positive organism at the beginning, gastrointestinal streptococci, and then with the time we have time for reactivation of virus, we have time for EBV, LPD, and basically the aspergillus is more or less a danger during the whole procedure. You see, here's the mucor, for example. This is the mucor. And here is aspergillosis. This is reactivation of herpes zoster. And this mucositis is herpes simplex. Well, going further, neutropenic fever is a specific issue, not only specific for stem cell transplantation, for all pediatric oncologists. And this is also like bacterial, viral, fungal, transfusion reactions. This is the thing that we have to take into account. And this is what we do, how we cope with when we have a kid with neutropenic fever. And then there is our standard operating procedure for neutropenic fever, which works very well. I have to say that basically, when I compare multi-drug resistance in my department with other departments, maybe south of Europe, there is not the same. It's basically not a problem in Stockholm or other Swedish centers, but it's a big problem in other centers in Europe. So we have this standard piperacillin, tazobactam, or ceftazidime if there were some problems with availability, or meronem imipenem. This is the standard. Then we go to post-transplant proliferative disease, which is quite a could be quite a life-threatening issue. And also, I must say that my colleagues and the adult department, they had 8 patients with explosive PTLD, and they couldn't save a single patient. And we haven't seen this on the pediatric side, but it happens. I have seen this couple, that's maybe 10. And it's difficult to diagnose because this is, as I stated here, non-specific signs and symptoms, and then you have to have quite a high index of suspicion. So if you have this, then you see the patient reactivates the ABV, go for this, check, and then there is something that we can do. We can lower or stop the immunosuppression because rituximab, and it works in the vast majority of patients, but some of them, they would need chemo, like CHOP, or maybe some of them would need CTLs. Then, neurological symptoms. It's acute, which happens directly after the transplant, or long-term neurotoxicity. There is a lot of factors that you see also with the viral infections of viral, fungal, bacterial. You can imagine that the child with aspergillosis in the SNS has quite a intensive, life-threatening neurological symptoms as well. We have drug neurotoxicity. The first come in the busulfan in the conditioning. So we do the prophylaxis. Now the treatment of choice is levetiracetam 10 milligram per kilo times 2 under treatment, under busulfan treatment. Very specific thing is posterior reversible encephalopathy, which is quite dramatic. It looks dramatic. It comes almost always when you have the patient on cyclosporin or tacrolimus. When you add solomedrol, for example, then you have a high blood pressure, and it triggers really dramatic press, which is seen in CNS, in the CT, or sorry, in MRI, and then you should switch. You should switch or stop calcineurin. So you see here's this typical findings: post-engraftment, headache, confusion, seizures, loss of vision. These patients, they usually have a difficult to treat hypertension, and this again triggers the symptoms. Treatment: anticonvulsants, stop, switch calcineurin inhibitors, and effectively control hypertension. Late complications after transplant is a challenge, absolutely. It is from this is unfortunately, this is true, that every system and organ can be affected. And we should be very, very cautious just to judge the patient, to see the patients quite often, especially at the first time, at the first period after transplant. It is from infections because of immunosuppression. We have secondary malignancies, we have endocrinopathies, cardiac or pulmonary dysfunction, cognitive and psychological sequelae. And we have been especially focused on these late effects, especially when the patient got the TBI, because TBI is like, it can cause all of them, only TBI, nothing else. So we have skeletal system with low bone mineral density, osteonecrosis, quite typical cardiovascular system, especially when the patient had before or during the transplant metabolic syndrome, hypertension, endocrine system, impaired growth and short stature, thyroid disorders, impaired gonadal function, impaired glucose metabolism, dyslipidemia, cataract, dry eye syndrome, ischemic microvascular retinopathy, cytomegalovirus, uveitis, retinitis, iron overload, renal dysfunction, pulmonary complications with bronchiolitis obliterans or bronchiolitis obliterans, organizing pneumonia. And this is also important, which we sometimes we don't think about that, but psychosocial and cognitive late effects, they could be really a disaster. Inclusive post-traumatic stress disorder for the kids and the family and the children at the department. Secondary malignancies, you have time, you need time to develop this, so it happens, but in the pediatric department, we usually don't see much of them. And that's why it's important that our kids, when they turn 18, they are reported to the follow-up on the adult side, but also for the post-transplant department. So we see there is a very complex, a lot of things to do, a lot of things to think about, and the collaboration and coordinating on the follow-up process is important. We can easily diagnose and handle the incidents when they happen, when the patient is on ward. But later, we should also keep eye and don't lose the patients from the follow-up. With this, I would like to thank you very much. Thank you much for your attention and being here with us. And hopefully, the next time we can touch the ground.